Welcome back to Tiny Teeth Talk, the study channel for dental students and residents. Hit subscribe and the bell icon to stay updated with every new videos. Instead of just skimming through textbooks, I have structured these PDF notes to give you the precise terminology needed for theory papers, high yield numbers of entrance MCQs, and the deep conceptual knowledge expected in postgrad vivas. Let's dive straight into the text. Today we are continuing our series with nitrous oxide sedation part 5, focusing strictly on disinfection of nitrous oxide units and the advanced mechanism of scavenging systems. Disinfection of flow meter, breathing circuit, reservoir bag and vacuum control unit cannot be ignored, considering that most of them are rubber goods. So today we will learn about A, disinfection of these parts, and also nitrous oxide gas can leak through various sources in a dental operatory and contaminate the surrounding air which a dentist and other dental staff breathe. The process of scavenging is very important and is required to keep nitrous oxide levels in a dental operatory to minimum. So B, scavenging of nitrous oxide. Let's start with disinfection. According to the Center of Disease Control and Prevention and the Spaulding classification system, the components of nitrous oxide sedation unit are categorized based on their risk of cross-infection. The Spaulding classification system is a widely accepted medical framework used to determine how a piece of medical or dental equipment must be cleaned and disinfected between patients. It was developed by Dr. Earle Spaulding in 1968. His core insight was simple. The strategy you use to clean an instrument should depend entirely on the level of infection risk it poses to the patient based on where it touches the body. The system divides medical and dental devices into the three distinct categories: critical, semi-critical and non-critical. Critical, these are instruments that enter sterile tissues, vascular systems like blood vessels or areas of the body where blood normally flows. Semi-critical, these are items that come into contact with intact mucous membrane or non-intact skin but do not penetrate into the sterile tissue or bloodstream. And non-critical, these items only came into the contact with intact unbroken skin, or they simply pose a risk of cross contamination via the clinician's hands. Intact skin act as an effective natural barrier against most microorganisms. First, flow meter. The flow meter, control knobs and chassis of inhalation sedation units are classified as non-critical clinical contact surfaces. They do not come into the direct contact with the patient's mucous membrane but are frequently touched by the clinician's contaminated gloved hands. So the protocol is first pre-cleaning. Wipe the outer casing, digital or manual flow tubes and knobs with a low to intermediate level disinfectant wipe to remove any visible bioburden like blood, saliva or dust. Then disinfection. Apply EPA registered hospital disinfectant with an intermediate level claim such as an alcohol based solution, quaternary ammonium compound or hydrogen peroxide based solution. So EPA registered hospital disinfectant is a chemical cleaning agent that has been officially evaluated and approved by the US Environmental Protection Agency for use in medical and healthcare facilities. Then the contact time. Ensure the surface remain wet for the manufacturer's recommended contact time, which is typically 1 to 3 minutes for modern hospital wipes. Then barrier protection. To reduce this chemical degradation of the flow meter dials, use clear plastic barrier wraps over the control knobs between the pediatric patients. A standard Viva trap for both undergrads and postgrads is how do you clean the flow meter. So remember, never spray disinfectant directly onto the unit. And why you should never spray disinfectant directly onto the unit? Because it can seep behind the dials and damage the calibrated gauge. Always use a damp wipe. Mentioning barrier protection shows the examiner you understand clinical longevity. Second is breathing circuit, semi-critical component. Breathing circuit include the corrugated conduction tubes, the nasal hood and the scavenging hoses. These are semi-critical items because they carry exhaled respiratory gases and can accumulate condensation and pathogenic microbes. Protocol, it divided into single-use and reusable system. Single-use, disposable systems. The gold standard in modern pediatric dentistry to avoid cross-infection is the use of single-use disposable breathing circuits and nasal hoods. For example, scented pediatric masks. These must be discarded immediately following the procedure. Reusable system. If the clinic utilize reusable silicone or rubber breathing circuits, the following protocol must be strictly adhered to. First is isolation and rinsing. Disassemble the conduction tubes from the flow meter. Flush the inside inside of the tube with the warm water and neutral enzymatic cleaner to dislodge mucus or saliva. So neutral enzymatic cleaner, because these components are typically made of a silicone or autoclavable rubber. Harsh alkaline or acidic detergents can degrade the material over time, causing it to crack, become sticky, or lose its seal. So the purpose of neutral enzymatic cleaner is to completely dissolve organic debris like saliva, nasal secretions, and oils before the component undergoes autoclave sterilization. And then sterilization, because this item tolerate heat, they must undergo steam autoclaving. Place them in sterilization pouches and run a standard dental autoclave cycle. Chemical high level disinfection. If the material is completely heat sensitive, it must undergo high level disinfection by total immersion in FDA cleared glutaraldehyde, orthophthalaldehyde, and hydrogen peroxide solution for designated time. Thoroughly rinse with sterile water after chemical immersion. So liquid immersion means the item cannot simply be wiped down, it must be totally drowned in the liquid. Then reservoir bag, semi-critical component. The reservoir bag functions as a dynamic gas reservoir and visually monitors the pediatric patient's respiration. It is exposed to the patient's expiratory backflow and moisture, classifying it as a semi-critical item. So the protocol is first detachment. Carefully detach the reservoir bag from the bag T of the flow meter. Then inspection. Inspect the internal and external surfaces for any moisture or cracks. If moisture is present inside, wash with the enzymatic detergent and rinse thoroughly. Then sterilization. Modern pediatric sedation system utilize autoclavable silicone reservoir bags. These should be inverted, bagged, and sterilized via steam autoclave to kill all vegetative microorganisms or fungal or bacterial spores. Then rubber or latex bag. Older rubber bags cannot withstand frequent heat sterilization. They must be clean, undergo high level disinfection via liquid immersion. Due to the complexity of rinsing chemical residue out of an enclosed bag, switching to autoclavable silicone or single-use bag is highly recommended. Then vacuum control unit or scavenging system. The vacuum control unit regulates the active scavenging of exhaled nitrous oxide and contain valve that draw gases away from the patient's nasal mask into the dental evacuation system. So the protocol is first surface wipe down. The external housing and control dials of the vacuum unit are treated as a non-critical surfaces. So disinfect them daily using intermediate level disinfectant wipe. Then internal line flushing. At the end of every clinical day, the vacuum lines linked to the scavenging system must be flushed with an evacuation system cleaner to remove bioburden or prevent microbial biofilm accumulation. Then inline filter maintenance. Many vacuum control blocks house a small solid debris trap or a filter. Clinicians or dental assistant must be wear full PPE to remove, clean, or replace this filter weekly, as it acts as a reservoir for captured aerosol microbes. Nitrous oxide is a highly effective inhalation sedative, but because it is not metabolized by the human body, it is exhaled entirely unchanged into the surrounding environment. This creates a profound occupational hazard for dental professionals. So research indicates a staggering disparity in ambient air quality based on equipment choice. So if a clinician has unscavenged operatories, ambient nitrous oxide concentration in the dentist breathing zone can soar between 3800 ppm to 24,000 ppm. If the clinician has scavenged operatories, active scavenging bringing levels down to the manageable range of 33 ppm to 409 ppm. Chronic exposure of unscavenged or poorly scavenged waste gas is epidemiologically linked to the severe systemic health risk, including reproductive hazards, neurological deficits, and diminished psychomotor performance. Consequently, the National Institute of Occupational Safety and Health recommends maintaining ambient nitrous oxide level below 50 ppm during clinical administration. An American Dental Association formally recommended the universal adoption of scavenging devices in 1980 to enforce these safety ceilings. So let's start with the definition. Scavenging is the process of collecting and removing the exhaled and excess gas to prevent them from contaminating the operating room. A functional scavenging system comprises three core components: the scavenging unit, the scavenging mask, and the vacuum pump or the evacuation unit. This is the mask, the evacuation unit. These components are configured into two distinct operational modalities. First is passive scavenging system. So passive system do not utilize an automated mechanical pump. Instead, they rely solely on the child's normal expiratory effort to force exhale gas through the exhalation valve in the scavenging cone and out through an exhaust hose. Technical constraint: because nitrous oxide is heavier than ambient air, passive exhaust tubing must be routed strictly along the floor level. Here is the exhaust tubing to exit the building. Now the back flooding phenomena. If a passive exhaust tube is sloped upwards like this, gravity causes the dense nitrous oxide gas to flow backward into the line. This creates resistance against the child's breathing and result in significant back flooding, severely polluting the operatory air. There is a specific clinical pitfall you must highlight in your papers and viva. Is this the back flooding phenomena? Due to these inherent limitations, manufacturers like Porter Instruments officially discontinued passive breathing system in 2009. Now, active scavenging system. Active scavenging relies on an external mechanical device to continuously pull waste gases out of the operatory at a calibrated rate of 40 to 45 liters per minute. Active system can reduce ambient room pollution by 90% or more. Clinically active aspiration is achieved via three mechanisms. First is high volume evacuation inline kits. The exhaust line is directly spliced into the dental unit's existing high volume suction lines like this using an inline vacuum control block. Central scavenging. The exhaust line connects directly to the dedicated medical gas wall outlet plumbed to a central facility vacuum. Then miniscave units, a compact self-contained external box system that integrates directly into the active breathing circuit, requiring a 15 mm external vent line and independent power source. Active scavenging is the true modern benchmark. For MDS entrance aspirants, keep your eyes on this exact numerical range, 40 to 45 liters per minute. This is a highly frequent MCQ hotspot in NEET MDS. Active systems utilize a mechanical pump calibrated strictly to this rate, which actively pulls waste gas out and reduce ambient pollution by over 90%. Various scavenging system. Matrix system, single mask with cap. So matrix system utilize a single nasal hood coupled to a localized scavenging cone system containing an exhalation valve cage. The drawback is as the child exhales, the valve rises to let gas enter to the coaxial tube, but the scavenging cap is very small and only occupies the top portion of the mask. This leaves an extensive perimeter area vulnerable to leakage. Because the material is less liable than the Porter-Brown system, poor facial adaptation rapidly spikes the ambient nitrous oxide levels. Then the Porter-Brown double mask system, widely documented as one of the most efficient scavenging system available. This design utilizes a coaxial tube attached to a true double mask. It consists of the highly liable soft inner disposable liner surrounded entirely by a clear outer nasal hood. The mechanism is during inhalation, a fresh gas flows into the inner liner. Upon exhalation, one-way flapper valve in the inner liner opens and redirects expired air into the outer hood where it is vacuumed away. The clinical advantage: a perfectly high anatomical fit is not critical to safety. The structural gap between the inner liner and the outer hoods create a continuous negative pressure zone. Any gas escaping from a poor perimeter seal, mouth breathing or patient speaking is immediately drawn into the outer hood before escaping into the room. Study shows it removes 71 to 91% of ambient nitrous oxide compared to alternative system and consistently maintains levels below the 50 ppm threshold. The Acutron system. This system features a coaxial tube where fresh gases travel through the white-gray corrugated line into the nasal hood configured with a clear outer collecting cap. The inner hoods are interchangeable, offering either autoclavable multi-use gray silicone mask, scented single-use disposable option to aid pediatric compliance. Low-profile high-vision system are silhouette versus axis. These modern configurations re-engineer the breathing circuit to eliminate the traditional bulky dental reservoir bag, utilizing continuous continuous demand independent gas flow. So this is a Porter Silhouette system and this is the access scavenging system. Let's compare it. So mask or tubing profile, ultra lightweight, low profile, minimal footprint for superior surgical access. Access slender lightweight index finger size for reducing bulk. Fixation method for both, loop comfortably behind the patient's ear, eliminate heavy chair clamping. Loops behind the earlobes allow unhindered patient head maneuvering. Infection control, entire circuit including all delivery tubings and mask is completely disposable. Only the nasal mask is disposable. Delivery tubings are reused, creating cross-contamination risk. Anatomical seal, integrated adhesive strip forms a tight, secure physical seal around the nose to block leakage. Excess legs adhesive strips rely solely on material tension against the skin. Delivery accuracy, employs a dedicated nasal cannula for direct delivery into the nasal meatus and legs and internal cannula mechanism. Sizing, so include dedicated sizers for highly accurate mask selection across 4 distinct sizes and offer 3 generic size like formal sizers for precise selection. Now, controlling nitrous oxide levels into the pediatric operatory requires a managing several technical behavior variables. So first is sampling probe placement. To accurate measure clinician exposure, monitoring probes should be positioned within the breathing zone, historically placed on the clinician's lapel at 21 to 25 cm from the nose, but modern guidelines suggest the probe to 45 cm to avoid localized readings skewed by exhaled water vapor and carbon dioxide. Operatory volume and ventilation. So nitrous oxide accumulates rapidly in confined stagnant spaces. Operatories must feature active heating, ventilation and air conditioning integration capable of executing 6 to 7 air changes per hour. Largely high ventilated operatory sees ambient gas concentration return to baseline exponentially faster than small non-ventilated room. Then gas flow rates and concentration. If the administered flow rate exceeds child's metabolic tidal volume, the reservoir bag overinflated, forcing excess gas to spill from the border of the mask. Higher concentration of titrated nitrous oxide linearly increase the concentration of trace gas leakage. Equipment integrity. Undetected micro cracks in aging rubber reservoir bags or loose coaxial tubing junctions are major source of chronic low level gas leaks. Patient compliance and clinical technique. Incessant crying, laughing or mouth breathing rapidly dumps nitrous oxide in the room air, while the application of the rubber dam provide a partial physical barrier that help redirect expiratory air back through the nose. Infrared imaging demonstrating that a rubber dam often simply redirect the waste gas out through its lateral border. Clinicians should pair rubber dam placement with high volume evacuation directly adjacent to the patient's mouth to capture this diverted gas. And that covers the complete high yield breakdown of disinfection and scavenging systems. If this structured notes makes your revision easier, make sure to hit the subscribe button, take your screenshots, comment the name of the PDF with the email ID. We will share it with you. We'll see you in the next video. Thanks.